Hi everybody, my name is Scott Pennington, and I have prepared an overview of my senior research project entitled Rehabilitation of a Medial Malleolus Fracture in a Division III Collegiate Football Player, a Case Study. Alright, so start off with a little introduction. I'm a senior athletic training student at Emory-Henry College, and over the past 2.5 years, I've got to witness numerous different experiences and various injuries and conditions, all ranging from the common cold to acetabular labral tears to multidirectional instability of a shoulder and to a medial malleolus fracture, which I thought was very interesting because I've never seen this before, and especially looking through the literature. Ankle injuries consist of 15 to 21% of all athletic injuries, but ankle fractures are still fairly common, and they occur at a ratio of 8 to 1, 8 being 8 ankle sprains to 1 fracture. And this was an interesting case, and so when the head athletic trainer, Davis, posted up numerous rehabs last semester of athletes who need extensive rehabs, and I seen this one, I was like, oh, I haven't seen this before. I was like, this would be a great opportunity. So I jumped on that opportunity, and I'm really glad I did because I've learned a lot from this project. But anyway, so the athlete sustained a medial malleolus fracture, and his joint was immobilized for 9 weeks. And usually, of course, with fractures, there will be surgical intervention. Some can be conservative treatments, but if you want to return to play, a lot of times there's surgical intervention and joint immobilization involved. But really, how long is too long for joint immobilization? And so with this 9 weeks of postoperative joint immobilization, it led me to my clinical question of, do early appropriate manual therapy exercises yield long-term benefits on joint range of motion than performing manual therapy exercises after a set immobilization period? And throughout this rehab process, I really just wanted to look at the effect of joint immobilization on range of motion, but see how manual therapy exercises really did help. So some basic patient demographics. So it was a male 21-year-old athlete who was roughly 6 feet tall and 175 pounds. So a little history on the athlete. He was generally a healthy person, no real issues at all, no previous injury to his ankle. And one day in practice, he was just running a route and he felt a pop. And he immediately went to the ground, and then that's when the head athletic trainer ran on the field, performed a thorough evaluation of the athlete, but for the lack of specific signs and symptoms suggesting a fracture, it was thought that possibly it could have been a posterior tibialis tendinopathy. But with the point tenderness around the medial malleolus and the clinical significance of the auto ankle rules, the athletic trainer referred the athlete to get an x-ray. And upon radiographic examination, it was determined that the athlete did sustain a fracture to the left medial malleolus. After the athlete sustained a left medial malleolar fracture, he then underwent an ORIF, or an open reduction and internal fixation surgery, and this was in November of 2013, and then rehab started in January of 2014. And of the 9 weeks of immobilization, the athlete was in a hard cast for 3 weeks and then followed up in a post-surgical walking boot for 6 weeks. All right, so methods of my design, of my case study design, was a single subject case study design. Independent variable was 9 weeks of joint immobilization, and the dependent variables was more specifically range of motion, but I also looked at girth measurements too. The rehabilitation program was designed into 3 phases, lasting a total of 15 weeks, and then and it focused on the last 2 healing phases of the healing process: the fibroblastic repair and the maturation remodeling. And how I went about the phase here is this is 9 to 10 weeks post-operative, and this is when we started, and then 10 to 14 weeks post-operative was phase 2, and phase 3 consisted of 14 to 24 weeks post-operative. And in phase 1, exercises that primarily went in phase 1, because it was only 1 week, and we addressed any lingering inflammatory issues, but where it was 9 weeks post-op, he didn't have a whole lot of swelling. But as you can imagine, 9 weeks being immobilized, he was pretty stiff. So mainly passive range of motion exercises, and infrared modality usage. I attempted to use ultrasound day one, and I didn't do it right over his medial malleolus, but I kind of went along the tarsal tunnel, and still caused him a lot of pain, and that due to the nature of the surgical fixation with the screws. So we didn't do it anymore. Phase 2 primarily consisted of strengthening exercises, more specifically isotonic TheraBand exercises, balance and proprioceptive exercises. And then the third phase consisted primarily of jump and landing mechanics, excuse me, proper gait mechanics, and sport-specific functional activities. All right, so throughout the rehab process, passive range of motion exercises were done with inversion, eversion, dorsiflexion, and plantar flexion. Strengthening exercises were only done with dorsiflexion and plantar flexion until 11 weeks post-operative because of the athlete's inability to perform TheraBand exercises for inversion and eversion. It wasn't until 11 weeks that the inversion and eversion TheraBand exercises were started. Balance and proprioceptive exercises went through various progressions with this, starting with two-legged balance with eyes closed, then one-legged balance with eyes closed, eventually progressed to more intense proprioceptive exercises within phase 2 and into phase 2 into phase 3. One-legged trampoline balancing, one-legged Bosu balance with ball toss, and then towards the end, starting at 18 weeks and 4 days post-operative, introduced a kind of more intense dynamic stabilization for Bosu balance, if you will. Had the athlete stand with both feet on the Bosu ball with his eyes closed, and for 20 to 30 seconds at a time, I would go around and kick different portions of the ball and make him work. Did you like that? With the modality usage, athlete really liked the warm whirlpool, and it was continued from 9 weeks and 1 day post-op to 15 weeks and 4 days post-op. He said that it made him feel a lot better, and that he felt like his ankle could move. It was more loose. Joint mobilization techniques, they were introduced at week 10, and at the end of week 10, I moved to grade 3 joint mobs with just the talocrural joint, or more commonly or more easily enunciated as ankle mortise, and then with the subtalar gliding as well. Isotonic leg exercises were introduced in phase 2, and that was the single leg extension, single leg curl, and the single leg press. I initiated a jump program at 18 weeks and 1 day post-operative. At this point, the athlete was stable with good strength and sufficient active range of motion to perform this program. Dynamic warm-up that I made up consisted of the athlete standing at the end line in the gymnasium, going to the half court and back, doing forward and backward lunges, high knees, butt kicks, a couple lap jog around the gymnasium to get warmed up. Functional activities that I decided to throw in. I made him do a T drill. Someone familiar with the T drill? T drill. I made up one drill called zigzag drill, and don't have a visual aid for this, but I will try to explain it the best I can. It pretty much consists of 2 triangles, a right side up triangle and an upside down triangle, and there is 5 cones within the whole drill, and they're placed 5 yards apart, and then the last cone is 9 yards. Why I didn't go 10 is because normally when I would do it in the gym, I didn't have 10 yards worth of room because of other sports practicing. So I had worked with what I had. Throughout the whole rehabilitation process, I had a basic guideline for criteria to progress, and that was usually consisted of a pain level below a 5 out of 10 on the pain scale, sufficient active range of motion to perform the activity, and the athlete's perceived level of ease. So that was the subjective part. So after the completion of our rehabilitation program, 3 main things kind of stood out in the data that I collected. one thing is the introduction of grade 4 joint mobilization techniques for subtalar and the ankle mortise gliding. My rehabilitation data versus study data that I obtained. And I'm getting ready to go to the next slide with tables of the data. And then with the laser. Okay, so here's with the joint mobilization techniques. At 11 weeks and 1 day post-operative, the top chart, that was before the initiation of grade 4 joint mobilizations. And as you can see, 38 degrees plantar flexion, 10 degrees inversion. And at 12 weeks and 1 day, so after only one session of grade 4 joint mobilizations, increased ankle plantar flexion 1 degrees and inversion 6 degrees. And that's a big jump and contribute some human error, probably 2 or 3 degrees of that, but still with 2 different range of motions increasing at least 3 to 6 degrees. That's pretty good clinical evidence. And this is my rehab data set that I collected with my athletes' active range of motion measurements. And then this is what I'm comparing it to. A study performed by Pascal Farsetti and colleagues looked at 2 series of patients, 22 patients each. The first series of patients, actually both series of patients, had either Weber type A, B, or C fractures. And then the first series of patients underwent ORIF surgery, and so was the second set. And with the first set, train of thought now, ORIF surgery, the first series of patients did not have an immobilization period. They were immediately put on a continuous passive motion machine. And the second series of patients had 3 weeks of immobilization before doing continuous passive motion. And so you see with mine and with this, it's dorsiflexion plus plantar flexion for the results. So 64 for my athlete for dorsi and plantar, and 34 for ankle inversion and eversion. And so my data showed that my athlete had more dorsiflexion and plantar flexion, but less inversion and eversion. And so with the discussion to look back at everything, due to the nature of the study being a case study with a single subject, there's no statistical significance that could be determined from it. However, with the data set collected, it does suggest some sort of clinical significance in a decreased amount of joint immobilization time due to the data set. Also, limitation could have been the surgical procedure with the medial malleolus having screws through it. It could have limited inversion range of motion and eversion range of motion. The inability to have been able to use ultrasound to maybe help up break up scar tissue and stimulate healing to help gain range of motion. That was the main. Oh, then the laser. Another result with the laser when I introduced laser and ice massage at 18 weeks and 4 days. The athlete had started spring football practice, and his pain was very high. He reported a 7 out of 10 and multiple times 4 and 5s out of 10. And for the last 4 weeks of rehabilitation process, his pain was a 2 out of 10 or below, and then was absent within the last 4 weeks of rehab process. All right, so in conclusion, my hypothesis was that the athlete the joint mobilization period would limit the athlete with range of motion. And it did in some aspects, we've seen with the inversion-eversion limitation. And again, due to the nature of the case study design, no statistical significance could be determined. All right, questions or clarifications on anything?